Hello, Abby.
Just a minute, John.
How you doing?
Hi, John.
How you doing, Abby?
Good, John.
I'm trying to fool you. I got two screens.
What?
I'm trying to fool you. I got two screens. You never know. Well, actually, I could say it's my twin brother.
You put on, where is your second screen? Yeah, okay, now I,
Double trouble. There you go. There's Miami Beach.
yeah, just a minute.
Okay.
Is Ahmad around?
Tool's not here yet. Amanda, you there, right?
I'm here. Yeah, I'm here. I'm just doing something.
Okay.
Okay, okay.
Okay, we've got about 6 minutes. And then people will pile in. Now, where are the elephants, Abby? Did they bring the king to the hospital?
What, John?
Did they bring the king to the hospital by elephant?
No.
Hey, Abby, like I don't have a very exciting life, man. I'm gonna think about things like that. I have nothing else to do.
It'll never reach if we go by elephant.
Okay, let me take that off. And I'll put a regular screen. So you guys been televising a lot lately, right?
Yeah, not that much. Tomorrow is Sam's meeting.
Yeah. Yeah.
Yeah.
It's a big one.
Yeah.
It's the biggest of the year. 50 presentations plus.
Yeah.
Part of the reason, Abby, that is a nighttime conference for me. That's 2 o'clock in the morning
Yeah. Can
until
imagine.
noon. Well, yeah, until noon. And as a physician, well, I'm an older person. I mean, that's to stay up all night, 2 nights in a row. It's not good for me because it kills those days. I
Yeah.
can't spring back like a youngster like you and just keep doing another 24. Those days are
Yeah.
gone,
Yeah.
but that's okay. Hello, Thompson Sidla, if you want to introduce yourself. If anybody wants to introduce themselves now, you're welcome to, because we're not really on the air and we haven't started recording. Well, actually, we're on YouTube. That's good. Whatever you're doing, drop it. That's good, Ahmed. I'm giving the baby a bath. I like that. Here's the king. He's here. Okay, trumpets up. Trumpets get ready to play. The king is here.
Yeah, John, your king is here.
See, I told the trumpet players to wake up. It's time to play. The king
Yeah.
is here. How you doing,
How are
Toll?
you, how are you, John?
Great, great. Ready for a good one.
Yes. You have been with me for several such big ones.
Yeah. Well, here's Abby. Abby's here. Let's see who else you want to say hi to before we. Does anyone want to say hi to Toll before we start? We start in the 2 minutes. Take the time to introduce yourself. I tell students that. Take the time. Just do it. Just say, "Hey, I'm so and so from Miami." Get to say hi. Just all you need to do is say hello. Because neurosurgeons remember that, Atul. You know that.
Yeah.
That. If you just say, "Hey, I'm John Bennett from Miami," you're going to remember me. Because if I text you, you really won't. You really won't.
Of course, John,
But
of course.
anyways, are you there, Ahmed?
Hi, dear John. I want to just ask you if you can share me, ID number for this. Someone asking for it. Okay.
Oh, okay. Let me get straightened out, then we'll start. Okay. 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 I see people raising their hands. Okay, raise your hand if you want to come into the panel. Okay. I think everybody can hear me.
John, could you share me the ID of this meeting?
The what? The ID. It's
ID.
on
Yeah, share me on WhatsApp, please.
I posted all that before. I'm letting everybody in the panel. I have no idea who's who. Is there anybody specifically you want me to admit that I'm missing? You can see the panel, right? Oh, okay, someone's raising their hand. Yeah, you want to come in, just raise your hand. I'll be glad to let you in.
Hi,
Welcome.
hello.
Yes, hello. Hi,
How
what's
are
your
you, John?
name? What's your name?
How are you doing?
Good, nice to, I'm glad you came.
Ayman
Introduce yourself.
from Libya.
Where you
I'm
from?
Dr. Ayman. I am from Libya, Neurosurgery. We
Oh,
have met
wow,
before.
great, welcome. We
Did you
we don't
remember?
have many Libyans here.
Ah,
You
but
came
it's
to the
been long.
right, you came to the right
Yeah,
place. The
been-
king is here.
yeah. Even you are king of neurosurgery.
That's it. Okay, you
I'm
ready to
learning a lot
start?
from you and the other colleagues. Thanks a
Yeah,
lot.
excuse me, we're gonna start. Abby, I mean, are you ready, Ahmed?
Yeah, I'm ready.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Neurosurgical TV, the home of this channel. We have the extreme pleasure of having the biggest star on the planet in this area of expertise of the neck, Atul Goel, who's done many webcasts all over the world, and we're really honored to have him here. And let me introduce Ahmed Al-Ghamimi from Yemen to introduce the king. Okay, Ahmed, it's all yours.
Thank you, dear John. Here's Dr. Ahmed Al-Ghanimi. I'm the special assistant to the global president of Walter E. Dandy Surgical Society. It's my honor to have this webinar with the king, as you say, John, and with the number one neurosurgeon in the Asia and maybe in the world in spine surgeries. So it's my honor to introduce and welcome Professor Atul Goel, who is the head of neurosurgery department at Lilivati Hospital in Mumbai. Um, Hi, dear professor. Can you hear me?
Yeah, Ahmad, thank you very much. And thank you, my dear John, for giving me such love, such affection, and such pleasure, and such an opportunity to send my message throughout the world on so many occasions. I have been doing these webinars and Zoom meetings since the times of COVID, and John has been broadcasting several, maybe more than 250 webinars or more with me over the years. And it has given me huge opportunities to send my message in the remotest of all corners of the world. So thank you, John, and thank you, Ahmed, Ahmed, for inviting me. And let me begin with a subject which I have talked about on several occasions, several and many occasions on this platform of Zoom. Let me share my screen. Just a minute. So this craniovertebral junction surgery, I have been involved in doing craniovertebral junction surgery for a very long time. And those who are in the business of craniovertebral junction surgery know my technique, this technique of one screw in C1, one screw in C2. I described this technique in 1988. Can you believe 1988, when I was 26-year-old resident, just qualified in neurosurgery? That is the year which I did this operation and described, and now you know this technique is one of the most favorite technique of C1, C2 fixation. The other thing is, you know what, in my own career, I'm seeing the indications of craniovertebral junction surgery have been increasing, and has been various new things have been added to the list, like Chiari malformation, syringomalia, platybasia, bone fusions, and things like that. So let me talk about my own subject, which I have been talking about. It is so important for every neurosurgeon, every spine surgeon. You know, when Ahmed says I'm a spine surgeon, I am a little bit unhappy because I'm not just a spine surgeon. I'm a brain surgeon. I'm a neurosurgeon. And I'm a skull-based surgeon more than anything else. Craniovertebral junction, every neurosurgeon should know about it. Every neurosurgeon should understand it because it is so complex. It is complex is the anatomy, complex is the technique, complex is the concept, complex is the philosophy, and everything is complex about it. But if you do it properly, you can make heroes out of our patients. You can give these beautiful smiles. You can make them like kings, and you can cure their neck. You can cure their hands. You can cure their legs, you can cure their breathing, you give new life. like no other subject in spine or in neurosurgery or in spine surgery. You give new life. On the other hand, you don't do it properly, you kill the person, you devastate the person, you create huge complication. The person will not live and the person will not die. So that kind of situation can happen with your wrong surgery. So I wish that you try to learn and understand, and if you get few more extra points, it will help. So let me try to again talk about this subject, which I'm sure everybody in the audience who is interested in craniovertebral junction has heard this talk on not one occasion, but on several occasions. So please listen to it again and probably enjoy it. So this spine is like a Y-shaped spine. The top of the pillar, this is a pillar, the top of the pillar is like holding the roof in a Y-shaped. There are two joints in the craniovertebral junction, occipito-atlantal joint and atlantoaxial joint. So these two joints form the joints of the craniovertebral junction. Occipito-atlantal joint is the most stable joint. Atlantoaxial joint is the most mobile joint of the body. So there are lots of muscles on the back of our neck, as we know. In front of the neck, there are hardly any muscle. You can put your finger in the mouth and you can feel the odontoid process. You can put your finger in the neck, you can feel the cervical spine. So all the muscles are focused on the back, and all the muscles are focused to keep the head straight, to keep the human body straight in standing position. We humans stand on two legs like no other animal on the planet. They're four-legged or wings or whatever, but two-legged, only human beings. So all the muscles of the spine are focused on the facets, and all the muscles of the spine are focused to make us stand and sit and run and dance and all those things. So these muscles are important. Any weakness of these muscles leads to instability. So this is the mouth. You take an incision, you are right on the odontoid process. The vertebral artery is in question. It goes sometimes very medially. It comes from C5 and then goes up straight, and then at C2 it turns medially and makes a loop. So this loop is important because when we move our head, this loop turns. And if this loop was straight, the artery would not tolerate this neck movement. So this loop is meant to facilitate neck movements. So it is very critical. One thing is there, you know what, in neurosurgery is not a minor subject. It is not a profession. It is life. You don't do neurosurgery to make a profession. You do neurosurgery because you love neurosurgery, and you have to live neurosurgery, and you have to perform to the best of the ability, and you have to do a lot of cadaver dissections and all those things. And you can imagine, if I have introduced this technique in 1988, how much cadaver dissection I must have done all the time in the anatomy lab. So this anatomy of vertebral artery is critical. So these are the two beautiful bones of the craniovertebral junction. This is the atlas. This is the axis. This is the odontoid process of the axis. Spinous process of the axis, or C2, is the largest spinous process of the body. Transverse process of the C1, largest transverse process of the body. Facets of C2 and facet of C1, strongest facets of the body. So these are the strength of the craniovertebral junction. Odontoid process is unique, and we have said in one of my papers that odontoid process is like disc. The function and odontoid process and the disc are similar. So what, atlantoaxial joint is the most mobile joint. C1, C2 joint is the most mobile. Occipito-atlantal joint is the most stable joint. We must know this thing, very important. Occipito-atlantal, most stable. Atlantoaxial, most mobile. Atlantoaxial instability is the most common instability of the spine. Occipito-atlantal instability is extremely uncommon. So Atlantoaxial instability means craniovertebral junction instability. Atlantoaxial fixation means craniovertebral junction stabilization. Occipital bone fixation is a suboptimal. You never need occipital fixation. So you see here, I used to do decompression and fixation long time ago. This must be about 30 years ago, 35 years ago. There is screw, and I introduced first screws in the occipital bone first time in the literature in 1987. So this kind of occipitoaxial fixation and subaxial fixation are very common procedures done by craniovertebral junction surgeons. But today I have to tell you, is occipital inclusion of the occipital bone necessary in the fixation? My answer is no, it is not necessary. Extremely uncommon, like some syndromic children or some high degree of trauma. Otherwise, there is no need for occipital fixation. So my answer is, when you do craniovertebral junction, do a solid C1, C2 fixation. Occipital inclusion is very, very rarely necessary or not necessary. I used to do a lot of transoral surgery. We introduced transoral plates from clivus to C3 first in the literature. This was metal implant first time in the literature. I used this one in 1994. Nobody had done metal fixation from the mouth after decompression. So this in 92, I did additional fixation. Retropharyngeal approach I used. Then I used to put iliac crest here, you see, after decompression. But now if you ask me, transoral surgery for craniovertebral junction is absolutely not necessary. For last 20 years, I have not done transoral surgery. I will talk about it. So facets, when all the muscles are focused at the facet, and if these muscles become weak, these facets become abnormal and facets become unusually aligned. And this is the focus of the weakness. When the muscles become weak, there is instability at the facets. So this is one beautiful article of mine, Facts About Facets. And we did this fixation, one screw in C1, one screw in C2, and this plate. And this is my technique I introduced in 1988, my first case. My technique involves, you see, this introduction of screws in the facet. When you put the screws are solid, cortical, the whole thing is like cortex. So you put a screw and this screw will never come out if you have put it correct. So facet screws are the backbone of my technique. My technique since 1988 involves three important steps: opening of the joint, removal of the cartilage, putting bone graft in the joint. So these are the three pillars of my technique. This was the case in 1988. Now my experience is beyond 4,500 such fixation over the years since 1988. I have done in children, which this is 6 or 8, 7-month-old child and fixation, and I have done in 90-year-old person. So screws, facets. During my time in 1988, no neurosurgeon knew about screws. No neurosurgeon knew about facets, and very few knew about instability. So this was a rare kind of thing which we started doing based on cadaveric dissection. So my first lesson to you is cadaveric dissection is important. If you want to do, you have to understand the anatomy. That is one. Second thing is occipital fixation is not necessary. When you do fixation, you have to do C1, C2 fixation. And other important anatomical issue is the C2 ganglion is right behind the atlantoaxial joint. So in 1988, I cut the ganglion to expose the joint. And this I call a window to the atlantoaxial joint. Now I do not cut the ganglion, I mobilize it up and down. For even very complex, very rarely I have to cut the ganglion. So anatomy has to be understood. So these are, if you divide the pedicle of C2 into 9 quadrants, your screw has to go very medial and up, because the vertebral artery is underneath. Of course, you have to have various parameters. You have to know where the arteries on the basis of CT scan, on the basis of CT angiogram, and your screw has to be directed medially and rostrally upward. So C1 screw is quite straightforward, but C2 screw is critical because there is vertebral artery. And you do this fixation and you give new life for all kinds of problems. So this is my position, head high under traction. This is a beautiful position. Those who want to do, I wish everybody does. But those who are really interested in C1, C2 fixation, because this is our domain, this is a domain where, even orthopedic people very rarely want to venture. This position, head high under traction. This position, your vision is clear down to the craniovertebral junction. Your venous congestion in the area is less, and you can do this operation under beauty. Whether you want to use navigation, I will suggest those who have navigation should use it. And those who are not very familiar with this area should use it. To tell you the truth, I used to do earlier in my career, but now I do not like to use neuronavigation because I have done so many cases, but still so many cases does not mean it gives me liberty to harm the person. So I have to be careful, and I have to be really, really careful. So I have also introduced this screw. This is transarticular screw called Megel screw. We know it. And one screw is in C1. This is double insurance. You see this patient. One screw is in C1, one is like Megel's technique. So vertebral artery is the one which we all, those who are going to do C1, C2 fixation will fear, will be afraid of. And we have to learn this. So we had introduced these three-dimensional models. Excuse me. These are three-dimensional. You can hold the model in your hand and understand the vertebral artery. This is abnormal location of vertebral artery. Understand where it is and accordingly design your screw placement on the basis of a model. So you see, this is a complex, also little bit unusual vertebral artery, but this model helped and we did this case. So this was also, I used to do models on every patient, but I do not use models now. You see, this is the model, this is the complex vertebral artery location, and you see how you can identify the vertebral artery and then design how to enter the screw. So these are, one thing is for sure, if you want to do craniovertebral junction surgery, you have to be 100%. If you are not very sure, you better don't do craniovertebral junction. You have to be absolutely sure of your understanding of your anatomy, of your technique, of the screws, of the metal, of the bone, the style of fixation. This is the magical bone C2 vertebra. You see there is odontoid. The other difference in this bone is the superior facet is anterior and inferior facet is posterior. You see this? Normally, all other vertebrae, superior and inferior facet are in line like this. Here, superior facet is here, inferior facet is here. So sometimes when you put your screw, this superior facet, you can do it because sometimes the vertebral artery is here and you can have a problem. So you can use the inferior facet also. Now we had described this technique, beautiful technique and quite easy and safe technique. You can put your screw here in the inferior facet if you are not able to put because of the vertebral artery location. So you see here what I have done is, see the high vertebral artery and I have put C2 screw in the inferior facet. Also the vertebral artery, you can mobilize the vertebral artery. You see, this is a small little article I had published. So you drill the dome of the vertebral artery and mobilize it. So if you see this, the vertebral artery is very high and very medial. So I have drilled it and mobilized it. I have a video, but it will take too much time. So I just pass it. And you see, this is the vertebral artery after inferior mobilization. You can use screw implantation in the spinous process also. And this is my article. First time we use spinous process, spinolaminar process, and then laminar screws. This we were the first one to talk about it. Although due credit has never been given to this for us, but this, as you said, this is the article, this is the publication, you can see it. So this screw in the C2 spinous process, spinolaminar line, screw in the occipital bone. I used to do, but I don't do them now. We also introduced this intra-articular spacers. We call them joint jamming technique in 2007. This can be used as a standalone method of technique, but I very rarely use it for this purpose, and these are the screws. Sometimes, as I have mentioned to you, I don't like to use occipital bone in any case. And sometimes this C1 facet can be very high, like in a simulation of atlas, in basilar invagination, in torticollis. And in some of these cases, I use transcranial method to introduce atlas screws. So the facet was high, so I did a small little craniectomy here and then extradural and put the screw here like that. So this is possible. So let me talk about instability. This you see here in extension, the odontoid is down, in flexion odontoid is up. I call it vertical atlantoaxial instability. When there is fracture of arch of atlas, the facets are dislocated laterally. I labeled it as lateral atlantoaxial dislocation. In bifid anterior arch, you see bifid arch of atlas, the facets go lateral. You see the bifid, the facets go lateral. And this is, I call lateral dislocation. The most important advance in craniovertebral junction surgery is the introduction of the concept that there is nothing like fixed or irreducible dislocation. The whole world was doing transoral decompression 20 years ago. I have no hesitation to say that this article completely revolutionized, completely changed craniovertebral junction surgery. Like the reduction, open the joint, distract the facet, and reduce and realign the craniovertebral junction. And now the whole world is doing this technique, but this is what completely changed craniovertebral junction. For this kind of patient, transoral surgery was the norm. Open the joint, distract the facet, manipulate the facet, realign the joint, realign the odontoid process, and stabilization. This is another disruption following trauma, realign and stabilize. Rotatory dislocation, nobody in the world knew how to treat rotatory. Only treatment was decompression. So open the joint, manipulate the facet, and you can give such beautiful neck, and you see rotate and straight, and in the evening of operation you can do. Basilar invagination was a very complex subject. Those who are in craniovertebral junction know it, that basilar invagination, this was our article in 1998 where we said, and the whole world was following this, that this is a fixed anomaly, decompression is the treatment. For this transoral decompression and for this foramen magnum decompression, this was the norm in the world. We introduced the concept of tight posterior fossa for Chiari, and we said that there is no need to open. I'll talk about it later. In 2004, my concept changed a little bit. For group A, for this group, we said that this is unstable. You can realign, open the joint, distract the facet, and for group B, we said that you do foramen magnum decompression. So this is what we said in 2004. Foramen magnum decompression was recommended for such group B cases. So this kind of basilar invagination, at that time, the only treatment was transoral decompression. But now you see, you can open the joint, distract and realign. And we have got several hundred patients now where we have not done any kind of decompression. Realignment is the treatment. You see how much it is going, and realign. In 1999, we said basilar invagination is unstable due to C1 over C2 listhesis, like lumbosacral listhesis. So this was my case in 2002. You see, this patient has basilar invagination, Chiari, syrinx. Listhesis or instability is the problem, and stabilization is the treatment, realignment, and no decompression. Now I recently introduced a brand new concept, and I have no hesitation to say a complete revolution in craniovertebral junction surgery, the concept of central instability. And we have described this instability for Chiari, for syrinx, and various other issues which I would like to show you. So when there is a chronic atlantoaxial, chronic, I'm not talking of acute, chronic, there are secondary protective or adaptive maneuvers by nature or by God. All these things which are mentioned, this is the father, these are all the children of the father. Chiari, syringomalia, basilar invagination, C2-3 fusion, clipal file, bifid, orthodontoidium, torticollis, kyphoscoliosis, all these things are considered today to be pathology. I am saying they are not pathology. They are secondary, they are protective. They indicate atlantoaxial instability and they are reversible following stabilization. So atlantoaxial chronic may be present with one child of Chiari, may be present with two children Chiari and syringomalia, maybe three children Chiari, syringomalia, basilar invagination. In short, my discussion is that if you find only case with clipal file anomaly, it is atlantoaxial instability. If there is only assimilation of atlas, it is atlantoaxial instability. If it is only clipal file, it is atlantoaxial instability. If it is only Chiari and syringomalia and bas, so this is a complete different kind of understanding. Now you see here, there is listhesis of C1 over C2, atlantodental interval increase, listhesis, there is no question, C1 over C1, C2 fixation. Type 2 is there is basilar invagination, no atlantodental interval disturbance, Chiari and syring. Look at the facets. You see there is retrolisthesis. This is clearly unstable. C1, C2 fixation is the treatment. Any kind of decompression, in my view, is a negative operation in the presence of unstable spine. Now look at this one. There is no facetal malalignment, but there is assimilation of atlas. There is Chiari, there are syring. So all these things, syrinx, Chiari, assimilation, clipal file, platybasia, are all children of one father, that is atlantoaxial instability. You stabilize and you create a radiological magic and you create a symptomatic magic and you give a new life to the patient instantly after surgery. So look at the facets. It gives you information. It gives you the need for stabilization. So basilar invagination, syringomalia, Chiari, and several other issues are all secondary to atlantoaxial instability. Atlantoaxial instability is the cause of Chiari and stabilization is the treatment. Basilar invagination, both group A and group B. Group A and group B, where I had recommended decompression, I am saying they are all unstable and stabilization is the treatment. And those who will have time, please go through these beautiful articles, which is my property, and nobody can take this beautiful property from me. So this is Chiari and syrinx. This is post. There is no problem here, no problem here. C1, C2 fixation. You see the syringomalia has reduced. No problem, no problem, no problem. Syringomalia reduced. Basically, syringomalia reduction or not reduction is not the issue. Issue is the patient. Patient will improve 100% of cases. Syringomalia will reduce 100% of time if you do a scan after 9 or 10 months. It will reduce 20 or 30% of time if you do MRI after 3 days. So basilar invagination, no problems, and the treatment is. So the whole world was doing foramen magnum decompression and decompression of the arch, removal of tonsil. So this paper was a remarkably different version of treatment where we said atlantoaxial stabilization is the treatment. So there was a lot of academic discussion in the world of neurosurgery, but that is all right. So Chiari and syrinx, no problem, little bit problem, fixation. So atlantoaxial fixation is the treatment. These are all children of one father, craniovertebral junction instability. No problem, stabilization is the treatment. This is another case. You see there is basilar invagination. This is another case of basilar invagination. This is, you see, this is syringomalia. See this, see this. This is post-operative image, only C1, no decompression. This is on the 3rd day of surgery. The syringomalia has reduced. This is after 6 months. Syringomyelia reduction or not reduction is not the issue. Issue is the patient. Patient will have remarkable. You see, I cannot talk too much because there is time limitation. I can talk for whole day on syringomyelia and Chiari. But here you must, that Chiari is a result, a child of atlantoaxial instability. Stabilization is the treatment. Syringomyelia will reduce, and it will reduce dramatically. See, you see, unstable. And I have got more than 600 patients now where I can go on showing you patient after patient. And this was my paper about 4 or 5 years ago where we talked about 388 cases. Those who are interested, and I hope that every one of you should be interested because this is common problem. You cannot keep on referring your patients here and there. You have to understand the philosophy of this issue. Chiari is protective, Chiari is reversible. I don't like to call it malformation. I like to call it formation. Formation is different, malformation is different. Even in pediatric age group, the Chiari malformation is a result of unstable atlantoaxial joint. And so Chiari is secondary, it is protective, it is reversible. Cervical fusion is a protective response to atlantoaxial instability. So if you see there is no compression here, but it is unstable. You fuse it, you give new life to the patient, but it is difficult operation. Difficult does not mean, difficult does not mean anything. It is difficult, but this is the operation. Bifid is secondary, bifid is protective, bifid is reversible. When there is bifid, even if there is no compression, even if there is no atlantodental interval, if there is clipal file anomaly, atlantoaxial instability is the cause. Os odontoideum is secondary, it is protective, it is reversible. You do fixation, there will be fusion here. There is no need for any kind of decompression. There is no need to include occipital bone in the fixation construct. Atlantoaxial instability is the issue. Syringomyelia is secondary. It is a sister of Chiari. It is sometimes sister is present alone. And we call it idiopathic syrinx. Don't call it idiopathic syrinx. It has a father, and that is you have to treat by atlantoaxial stabilization. And I can only promise you, I can only bet for you that you will have a patient who will have a new life. And this new life cannot ever come by any kind of shunt or CSF drainage, and that is not such a great operation. Short neck, short spine, torticollis. You see this operation I did, and after 6 or 7 days after surgery, see the smile, see the neck, hands are better, neck is long, and things like that. So you have the power in your hand to make these children big and strong and wonderful. These I have in my series 5 patients who have become doctors. And recently I got a patient, he said, I want to become a neurosurgeon. So I was a little scared. I said, just hold on, my dear. Another beautiful thing, just my last thing, because this kyphoscoliosis, we should, when you have an idiopathic kyphoscoliosis, just don't start taking screws and rods and all those things. Many of these kyphoscoliosis are due to abnormal craniovertebral junction or central instability. When there is Chiari and when of course, you don't have to do anything but do C1, C2 fixation. Even when there is no Chiari and syrinx, you can have. So central or axial atlantoaxial instability is a huge new thing in the field of craniovertebral junction. When you see bifid, even if there is no compression, it is C1, C2. Even when you see syringomyelia, even when there is no compression, you have to do C1, C2 fixation. So I have no hesitation to say, my dear friends, that I completely demolished transoral surgery from the books of neurosurgery and spine surgery. And now today I am saying in front of you, without any doubt or hesitation, that I will demolish foramen magnum decompression from the books of spine and neurosurgery, and this operation is going to soon become history. So thank you, my dear friend. I hope you enjoyed this lecture. This is, my lifetime of work on this subject since several years, and more than 4,500 cases I have done C1, C2, but I have done several other, issues here and there. So this is so Ahmed, over to you, my dear friend.
First of all, I'm so grateful and appreciated for being with us today. It's a great honor for me in person and for us as a Dundee Society globally. By the way, I would like just to tell you that Professor Salim just urged me to talk with you and to greet you that we are so blessed and honored to have you with us today.
Thank you, Ahmad. It is, today I was having my throat is not working, and I was having some fever. So I was wondering whether I will be able to talk. But when I start talking, I keep on talking. So thank you, Ahmad.
It's good.
Thank you.
Okay now, John.
Yes, thank you very much, Atul. Another great one. Okay, Adnan, it's all yours, Adnan.
Uh, uh, I would like just to say something here,
Sure.
about questions. Here is here is someone asking, do you use bone graft to pack the C1, C2 joint? If yes, where you harvest the graft from?
Yes. So this is a very important question. Very important question. See, when you put metal, C1 and C2, the metal will hold the region for 2 months or 1 month. And after that, the bone fusion has to occur. So I put bone graft in the facetal articulation inside the joint. So that is one place which I like to put inside the joint. And second thing is I, remove all the muscles of C2 spinous process, decorticate the lamina of C2, decorticate the arch of atlas, and put a lot of bone graft in the midline. And I harvest the bone graft always for so many years from the iliac crest. I have never used any artificial bone or rib graft or anything. So iliac crest is my source of bone.
Here is Dr. Hamid, your junior from Yemen. You know him, of course. He said, it's a true honor to have you with us today. Your vision, leadership, and lifelong contributions to neurosurgery continue to inspire us all. Wishing you every success as our future WFNS president. You truly have our full support and respect.
Thank you very much. See, my issue is all my life. You have heard that I have been in the anatomy with the cadavers, with the patients, and with my articles and papers, and those young people who are watching me. I have to tell you, just to not to showcase my work, but I have now got more than 800 papers on PubMed. So you can imagine how much time I have spent of my life writing and how much time in my life I have spent in the operation theater. So this new version of me contesting for election and coming in politics is a little bit new thing for me, and I hope this new venture is successful and it gives me some newer vision and thoughts of neurosurgery.
Last question. Someone asking, what are the steps to be taken if you encounter vertebral artery injury?
So that is that is a big chapter in itself. And I have given this lecture on several occasions as to how to handle the vertebral artery injury. So vertebral artery injury can happen when you are putting C2 screw. C2 screw you are putting, you can damage the vertebral artery. So when you are putting C2 screw and the artery bleeds, so what you have to do is you immediately tighten the screw. Don't stop it. And don't try to pack it with any bone wax or anything. Just tighten the screw and use it. The chances of when you damage the vertebral artery, there are possibility of, vascular insult. But the chances are not very high and not very, you should not get too much worried about if there is bleeding. You continue your operation and finish the operation. If the bleeding occurs on the arch of atlas or in the lateral gutter, you can hold with two clips and suture it. That is also a possibility, but it is a little difficult thing because there is a lot of venous bleeding in that area and you can have some problem. But that is the way to treat in the lateral gutter and in the arch over the arch of atlas.
Well, last question. Here is someone asking about children. Just a minute. Yeah, for children, what is the limit age for C1, C2 fixation?
What's that? I didn't understand. What is that?
What is the limit age for C1, C2 fixation?
There is no limit age, no limit age. I have done in, 5 or 6 months. I have done in 90-year-old man also. If it is indicated, you do it. Because if you do it, you have the possibility of absolutely fantastic clinical outcome and radiological outcome and new life, new life.
Well, if you permit me, and if you, John, permit me also, I would like to go to the next speaker. Is that okay with you, John? And you,
Yes,
bro?
of course, I want to hear.
John, is that okay for you?
Yes, we have plenty of time for the king.
Okay, we can discuss all the questions later, I mean. With the professor, I mean. Can I go ahead?
Go ahead.
Yes, please, go ahead.
Well, here, let me now introduce the next speaker. He is the Dr. Adnan Awadi. He is the chair and the head of neurosurgery department at Tatora Modern General Hospital in Yemen, which is the reference and the largest hospital in Yemen. He is also the president of the Yemen Neurosurgeons chapter. So it's yours, dear Doctor.
Thank you, Ahmed. Thank you, Dr. Atul. Thank you all. Today we will talk about the C2 fracture, dislocation management, classification. I'm Dr. Adnan Abdullah Al-Awadi, consultant neurosurgeon at Thawra Modern General Hospital. So we'll start with introduction, then anatomy classification for C2 and patient examination, the management options. For the classification, the C2 and our cervical fracture are not as like the subaxial or thoracolumbar and sacral classification. The vertebra have not a uniform vertebral anatomy, and actual fracture of the axis represent 20% of cervical fracture. Disappear or what?
It's okay. It's okay. You can go ahead, sir.
You see everything?
Yeah.
But I didn't see
Go
the
ahead.
screen. The screen is gone for me. Okay. Also, the age group is also for children below 9 years, 67% of cervical spine occur in the upper segment of cervical spine. And normal cytochondrosis may be mistaken for fracture. The C2 is the most common vertebral injury in children, and 10 or to 15% of cervical fracture is in the odontoid process. The stability, we have two type of stability, as the clinical stability defined by White and Benjabi, which is the ability of the spine to under physiological load to limit displacement, so it can prevent injury or irritation for the spine or spinal cord nerve roots. The second is the mechanical stability, which can be defined as the ability of the spine ex vivo to resist forces. The anatomy, you have basic anatomy that this is the axis which show odontoid process, which is the pilot for the movement and the rotation for the skull. It represents of 45% of the axial rotation of the spine. The articular process, and this is the odontoid in the axial view, spinous process, and lamina, pars, and pedicle. These old structure are holding by so many ligaments. The most important is the cruciate ligament, which represent the transverse ligament, and the apical ascending ligament, and the descending band ligament. Also, this is the alar ligament, which attach the odontoid to the condyle. This is a sagittal view showing the ligament which attach the odontoid and the C2 to the column. This is the apical ligament, and this is the transverse ligament. This is the descending ligament, or the tectorial membrane. Here is behind the transverse ligament, which is a continuation for the posterior longitudinal ligament. Now you see the chondrosis of the C2, which two neural arch and body, and the dens, which have two ossification center. For the classification of the C2, we have so many classification of the C2 fracture living system and grading system of Francis Anderson for odontoid. But I prefer the AO classification is easier to understand and simple. This classification of O is for the upper cervical spine is dependent on the three segments of the component and three types of fracture. You have a neurological condition and modification. For the three segments, which is the condyle, the atlas, and the axis. And for the regions, it have three regions. Region 1 is the condyle, which the joint below it, with the occipital C1 joint, and the region 2 is C1 ring with the C1 C2 joint injury, and the other third region is C2, and the joint below it is C2 C3 joint injury. For the three types of injury or fracture, is we have class A, B, and C. For class A is only bone injury without significant ligamentous tension, band destruction, and it's a stable injury. For the B type, it's a tension band injury, ligament with or without bony injury, stable or unstable depending on the injury specification. For type C, it's a translation injury, any injury with significant translation in any direction, which is unstable injury. For the neurological classification, it's dependent on the neurological condition of the patient, from N0 neurologically intact to M4 complete spinal cord injury. NX cannot be examined, and plus if there is a continuous spinal cord compression. There is a modification for or modifiers for this classification. If there is injury at high risk of non-union as a type 2 odontoid fracture, injury with significant potential for stability, instability, patient-specific factor as age, and vascular injury or abnormality affecting the treatment. The end result for our nomenclature for the classification is to specify the type of the region of the fracture, and the type of the fracture A, B, C, and the neurological condition. We will discuss now the C2 fracture. We have fracture for the body or fracture for the odontoid. For the body, we have hangman fracture and odontoid fracture. For type A, it's considered for hangman and odontoid. Tension band injury, this B, and fraction dislocation type C. This is also the body fracture or hangman fracture, and this is the types of odontoid. The tip of the odontoid is class 1, and class 2 fracture through the base of the odontoid, and type 3 fracture in the body below the odontoid base. We have type also 2A, which can have a little bit of the body with the base of the odontoid. We have specific topics. It's osteo-odontoidum, which is a smooth bone ossicle of variable size, which is attached to the or separated from the odontoid beak. It's may be fused with the clivus and mimic type 2 or 1 odontoid fracture. Its etiology have two etiology, either congenital or traumatic. Congenital developmental anomaly, non-union of the dentist to the body of the axis, however, does not follow non-ossification center. And in the acquired, is postulated to represent an old ununion fracture injury to a vascular supply or developing odontoid. We have two anatomical types. The orthotopic ossicles move with the anterior C1 and as this one. And this topic ossicle is functionally fused with the basion as shown here in this picture. Mesa blocks anterior to the C1 arch. A true osseous odontoism is rare, and the ossiculum terminal non-union of the apex at the secondary ossification center is a more common. For patient examination, we have clinical evaluation and neurological evaluation, radiological evaluation. For the clinical evaluation, first, it will be at the sense of the trauma with basic assessment or primary survey ABC for the airway assessment, breathing, and cardiovascular, cervical collar, and disability, which basic neurological assessment is carried out at the level of consciousness grading by Glasgow Coma Scale. For the neurological examination, we use the ASIA or the INCS1, INCSI, which is the ASIA grading system for the power as a 6th grade, and motor sensory function, and for the reflexes to assist the reflexes, and the sacral sparing test. Don't forget to do the anal if this is complete to assist if there is a complete or non-complete spinal cord injury. And last, for the cranial nerve function. Radiological assessment is an X-ray, CT, or an MRI, which can identify the location and extent of injury, determine the feature of vertebral instability, assess the severity of neurologically compression and injury, to classify injury pattern, and identify multi-level injury. And some recommended to do CAT or CT angio for all C2 fracture. X-ray, we have EB, lateral view. To discuss, this is show a C2 type C dislocation, lateral view, and also this lateral view showing space between the anterior odontoid and arch of anterior arch of the C1. Open mice view shows subluxation of the C1 lateral mass over the C2 body, and we have also a dynamic flexion extension, which should not be done only in fully conscious oriented and obey command patients. CT scan can reveal associated injury as well as to rule out suspected fracture which are not present. We have this axial view showing the body fracture. Coronal view show the odontoid fracture. And this is the sagittal view, show the anterior-posterior translation of the fracture. The MRI gives a detailed image of the soft tissue, disc, and nerves. This case, this is the axial view. And it's also the coronal view, which can show also the odontoid, and in T2 we can see the hyperintensity associated with ligamental or acute ligamental injury and the transverse ligament, as in this case. This is the surgical view. Management options. First of all, for any fracture, we have many fixed management strategy. It's reduction, cross the open, immobilization, and fusion. There is factor affecting management options, which include the general condition of the patient and the neurological condition, the age, and fracture reduction, and the type of the fracture with the associated fracture. Management option, either non-surgical or surgical treatment. The non-surgical treatment is soft collar or hard collar orthosis, which include hollow vest for old patient or young patient, and Minerva cast for small children. And for the surgical treatment, we have multiple options. For the non-surgical, it's almost for the region of type 3, which is, we will discuss C2, type A and B, which main indication undisplaced fracture, contraindication if there is wound or burned around the occipital cervical spine. The advantage, initial pain management, and the disadvantage is the pressure sore. And for the surgical treatment, for the region 3 type A, we have anterior odontoid screw, and we will discuss it in more details. And there is a posterior C1, C2 fusion. And for type B, we have posterior C2, C3, and also we have anterior C2, C3, ACDF, and there is a direct osteosynthesis of the isthmus. For type C, we can use the posterior C1, C2, and C1, C3, or anterior fusion C2, C3. We have also to be reminded if there is a combined fracture as associated fracture, as here is discussed, if there is a C1 with hangman or stable or unstable, collar, halo, and surgery. If C1 type 2 odontoid fracture with the anterior dental interval less than 5 millimeter, you can go for collar or surgery. And if there is more than 5 millimeter displacement, halo or surgery depending on the patient condition. For management of osseous odontoideum, we have, if the patient is neurologically intact, we can go for conservative treatment. If there is patient having neurological symptoms, posterior C1, C2, internal fixation and fusion. If surgery time rigid, no need for halo, but if there is non-rigid operation, you can use the halo. Immobilization is recommended. If the patient with irreducible cervicomedullary compression or evidence of associated occipital-atlantal instability, occipital cervical fusion plus C1 laminectomy can be done. If this is irreducible or the compression is not done, decompression is not done through the posterior, and there is still compression from the anterior by the osseum odontoideum, we can consider ventral decompression by transoral odontoidectomy. I will now speak about the most common surgical approaches for the upper cervical spine trauma. Surgical approach, we have posterior approach and the anterior approach. For the posterior approach, we have either C1, C2, or C1 to C3 fusion using polyaxial screw connecting by rod. The option for C1 screw is also through the lateral mass. And for C2 screw option, we have either placed in the pedicle or bars screw placed in the lateral mass. That's not recommended. We have a higher incidence of vertebral artery injury. And for the laminar screw, for C3 screw is either lateral mass or C2 laminar screw. There's another option for the posterior C1, C2 posterior transarticular facet, and last one are posterior cervical wiring and fusion, lessly used nowadays. For the anterior approach, anterior C1, C2, Cajun plate, and the odontoid screw. This is a diagram showing the C1 screw position, either C1 lateral mass screw, which is below the arch, and mid position in the inferior facet, and it had the angulation of 22 degree upward direction of the screw. We have another entry point, which is the posterior arch lateral mass screw, which directly in the arch in the same position of the midline, but the trajectory is straight, more straight than the C1 lateral mass. C2 screw, we have a pedicle screw. Pedicle is more wide and can be easily detected through Benfield detector there, and you can assess the midpoint from the mediolateral aspect of the pedicle, and this is the entry point with the trajectory to the C1 tubercle. It's about 25 degree. For C3 to C6 screw lateral mass, we have three options for the entry point, which Anne Megrel and Roy Camel. For the anterior odontoid screw, which mostly done for the type 2 undisplaced fracture in the specific patient, we will now see the contraindication to see what other possibilities to do for the odontoid screw. First of all, contraindication is for fracture of C2 vertebral body, except cephal hit type 2 fracture, and disruption of the transverse ligament, large odontoid fracture gap, and irreducible fracture, age of the fracture, if there is sclerotic margin, if the age of the fracture is more than 6 months, the fusion rate or non-fusion is high. Patient with a short neck, short or thick neck, barrel chest, may be difficult to position the patient and to introduce the screw, as the chest will be encounter you during the insertion of the screw. Pathological odontoid fracture and fracture line in oblique orientation. We need the three basic or the basic component of the odontoid screw is the guide wire, a drill bit, and the lag cannulated screw and the screwdriver beside the CR. Now we position, this is the basing position with C arm, show this is the odontoid, and this is the owl to represent the entry point. This is in the AB view, and this is also in the lateral view. This is the C2 body, lower border, beside the C2, C3 disc space, and this is the C1, and this is the odontoid. Now we start with the guide wire positioning in lateral AB view. This is inserting the guide wire to position, but after insertion in the lateral view. Also, this is after guide wire, after insertion in the odontoid screw with piercing of the tip of the odontoid. Then insertion after insertion of the guide, drilling through the guide wire and insertion of the odontoid screw. And this is the X-ray view and AB view with piercing of the odontoid tip, and this is in the lateral view. We will now discuss some sample of our cases. First one is we will discuss three types of or two types of cases. Cases which can be classified according to AO classification, and some cases cannot be AO classification cannot be applied, as we will discuss later. The first case is a female, 32 years, with post RTA with neck pain, neurologically intact, X-ray show, type 2 odontoid fracture, and operated for simple anterior odontoid. The C2 case number 2 is a male patient 25, 1 month, was fall down, neck pain, neurological condition intact, sensory intact, X-ray show C2, C3 spondylolisthesis, which can be classified as C2 type C, N1 classification. For the AO classification, they will see, this is the AB, and this is the lateral view of the X-ray show translation of C2 over C3. This is the MRI view, which show disc disruption and translation of C2 over C3. This is the translation injury is type C in AO classification. Simply we go for the anterior approach C2 C3 fusion with the cage. This is a dynamic X-ray after the operation, and this is the CT scan post-operation. The third case, which also go with the AO classification, is 65 years male patient, 2 days post RTA, neck pain, upper limb. There is upper limb fracture, neurologically intact, sensory and reflexes. X-ray show type 2 odontoid fracture with anterior displacement. This type is classified as a C2 type A, N0. But the approach for this patient was not anterior odontoid because the patient was old and short neck, barrel chest, and anterior odontoid screw cannot be applied for these causes. We go for the posterior C1, C2, 3 fusion. This is the CT scan showing the odontoid fracture. This is show the displacement of the C2. We go, this is the position of the patient in a prone position. We go for the C2C, C1 to C3 fusion. This is the post-operative image. X-ray in AB and lateral view, and this is the CT scan reconstruction view, and this is the sagittal view of the post-operative show reduction. The fourth case, which cannot be applied in OO classification, this is one limit of the AO classification, which cannot be specified for multi-segmental injury. This case, unknown history of trauma, complaining of neck pain, radiology show odontoid fracture type 2 to 3, and atlantoaxial subluxation. This is the CT scan, which show this is also old fracture. Old fracture with sclerotic margin of fracture line. Also, this is subluxation injury or tilting of the neck, which in a reconstruction view, you can see the subluxation of C1 over C2. This is the MRI view. For this case, we done posterior C1, C2. The other case is we think is osseous odontodon, as no other specific diagnosis for this case. is 40 years old patient presented with gradual lower and upper limb weakness, neurological condition, motor upper grade 3 and lower also 3, sensory damage in the upper and lower, hyperreflexia in both upper and lower limbs. CT scan show. This is the CT scan which show posterior atlanto-occipital dislocation and displaced type 2 fracture odontoid with sclerotic margin and suspected osseous odontoma. This is, I said, this is the CT scan, and this is the MRI showing posterior displacement of the C2 fracture and displacement posterior of the atlantoaxial joint. This is the axial MRI. First of all, we go for the posterior occipital and C1 to C3 fusion. And after the operation, we didn't find a complete decompression from the anterior part of the spine. There is continuous compression or for the cord. We go for the anterior approach for anterior odontoid odontoidectomy transoral. This is the drilling of the odontoid. This after more odontoidectomy are done, and the end result for this case. This is the preoperative showing here the cervical spinal cord compression, and this is after anterior odontoidectomy and posterior fusion. The last case is 54 years male patient, 2 months post-RTA with neck pain, lower and upper limb weakness, motor power grade 2 and lower grade 3, damage sensory with hyperreflexia and lower limb, CT scan, posterior atlanto-occipital dislocation, type 2 odontoid fracture, C4 and C5 comminuted fracture, and kyphotic angulation. MRI show severe spinal compression. For this case, I presented here as a limitation of O classification, as this is until now this case is mostly as a pathological due to minor trauma. This is the axial CT scan showed the destruction of C4, C5. This is the sagittal view showing the type 2 or type 2 fracture, destruction of C4, C5 vertebra with severe compression of the spinal cord. This is CT reconstruction view, and this is the MRI view. This is the coronal view, and this is sagittal view, which shows severe compression of the spinal cord. This is the CT angio. As we go, we are afraid of the injury for the vertebral artery. For this case, we go for anterior corboctomy and cylinder cage placement with plating. This is the MRI view. This is the final postoperative view. We didn't do anything for the C2 fracture here, as the main issues was for the severe compression of the spinal cord due to the comminuted fracture of C4, C5. We'll go for summary. Unlike the subaxial, the upper cervical spine have a specific shape, and various classification system cannot be applied. All classification for the upper cervical trauma is a simple, easy to describe, and make communication between surgeons more easier. AO classification lack how to describe multi-segmental multi-level fracture. Most C2 fracture can be managed non-surgically. Routine follow-up X-ray for conservatively treated patient for signs of non-union. Dynamic X-ray study should only done in a fully conscious and cooperative patient and neurologically intact. Many factors may affect the management of or the plan of management for any case. And thank you.
Thank you, dear Professor. I would give the mic to Professor Atul if he can comment or say anything.
Yes, I'm there, Ahmad.
Yeah, do you want to comment or say anything about Dr. Adnan's lecture?
See, fracture, C2 fractures are quite common, as we have heard. Hangman fracture and odontoid fractures and so many other fractures are there which can happen. And I have recently published one of my series of, I think, about 120 cases of C2 fractures in world neurosurgery. Most important issue is odontoid fracture when it happens. You see, as we have seen cervical screws for odontoid and all. I used to do, but now I don't like it. If I feel there is instability due to odontoid fractures, the instability is atlantoaxial instability. And when there is instability, I like to do posterior fixation. So in general, many people do anterior, many people do transpharyngeal and retropharyngeal, but I like to do all odontoid fractures by posterior root C1, C2 fixation. If there is hangman fracture and there is C2-3 dislocation, maybe in some cases I like to do C2-3 fixation also, but those are little bit rare. In general, for when instability is expected in fractures of C1 and C2, that instability is atlantoaxial instability, and that instability I like to do posterior fixation.
Well, thank you, Professor. After a month, there will be a WFNS conference in Dubai. And during this conference, there will be a WFNS election for having, the new WFNS president. Regarding this occasion, someone sent me on private some questions for Professor Atul, as he is one of the candidates for WFNS presidency. So the first question, Professor Goel, you have always been strong advocate for education and mentorship in your surgery. What do you think should be the main priorities for the WFNS in supporting young neurosurgeons, especially from developing countries?
See, Ahmad, you must know that I am from India, and all my life, I have worked in public hospitals, which are, public hospitals in India are completely free. And when I have spent my lifetime in treating poor people, I have treated the poorest of poor people in the world at that time. Now, of course, the things are a little different, but my power is the numbers. My power is the complexity of cases. So you know what, when we talk of developing countries and all the time we look for developed countries and they are doing this and they are doing that. We have also in the developing world, we also have our own powers. Our power is the numbers. Number of cases that we are doing. In Yemen also, you have the numbers. You have so many patients needing operation. So one is that you have the confidence in your own self, in your numbers, in your complexity of cases. Neurosurgery, as I have said, is not a profession. It is life. Neurosurgery is life. You have to love neurosurgery. You have to live neurosurgery. You have to dedicate your life to neurosurgery. You have to work in your operation theaters, and you have to, of course, have the vision. You have to go for fellowships, you have to go for training, you have to go here, you have to go there. Basically, what I have to say is, I don't consider that, you have to, neurosurgeons, all neurosurgeons who are becoming neurosurgeons are strong people. They have to have confidence in themselves. They have to confidence in the working environment, and they have to do what they are doing and look for fellowships here, look for fellowship there. It is very easy to get fellowships in several places all over the world. Take some training, come back to your country and do the work in your country. For instance, I was also in America. I was also a licensed practitioner in America. I left American neurosurgery and came back to India to work in a poor environment, in an environment which was giving me cases after cases, cases. I became a neurosurgeon when I was 26 years old, when I became chairman of my department when I was 36 years old. So that advantage I got, and I think I don't ever regret why I did and what I did. Only thing is, you should have your own ambitions. You should have your, and you don't have to depend on somebody will help you. What WFNS will help. What WF, you have to help your own self. So, of course, there are people to encourage you. There should be some avenue to give you training, if you want to learn craniovertebral junction. And you want to come to me, there should be people who should be ready to accept you. There should be people who should be ready. You want to do vascular neurosurgery, you want to do skull-based neurosurgery, you want to do pediatric neurosurgery. There are centers who are top of the line, but basically, first of all, one has to have your own vision, own strength. Go for fellowship, go for training everywhere. So many training we have learned from US, we have learned from Western world, we have learned from so many other. But basically, you have to be confident of your own standing and your own work and your own environment, your own mother country, when you have to, do neurosurgery where you are doing. Don't always look for greener pastures. I will go here, I will go there, somebody will give me training. You have to look for training. You cannot be dependent on somebody. What World Federation will do, you have to do for World Federation. Means always you have to look for, give me some, give me, what, give me some. You have to say, I am here to give you. This is my, vision.
Thank you. Next question. Professor, you have built strong collaborations across the world and inspired many neurosurgeons globally. How do you envision the WFNS playing a strong role in uniting neurosurgeons and sharing expertise internationally?
Currently, as you know, you may not know that there are lots of issues in World Federation. There are divisions in European society, there is Spanish society, there is English society, Belgian society, Japanese, so many American society. There are so many withdrawals. They are not, they are not in World Federation. So if I have to become president, my first and foremost aim will be to unite those people and those who have become unhappy and those who are leaving World Federation. That will be my first aim, to unite them and get them back into system. And that is not an easy challenge. That is a big challenge, but that will be a task and that has to be done. If neurosurgeons, if the World Federation has to survive, if the World Federation has to go further, all of us have to live like brothers and sisters, of course, and then take the whole society together. So that is a challenge and that has to be sorted out. Ahmed, do you know about the problems the World Federation is facing? But those problems have to be settled. Then, as you rightly said, younger people have to be promoted. Weaker people have to. I don't like to call myself weak. If I'm in India, I don't want to say I'm weak. If you are in Yemen, don't say I'm from weaker country. I'm from the strongest country, you have to say. And then you have to put your hand forward. I don't believe in the fact that I'm from poor country, I need help, and what nonsense. We did what we did in India. At that time, we did in the most poorest environment. If you always say, I'm poor, what poor? We have, when I have given lectures in very poor countries of the world where I say, I want you to become the best in the world. You cannot always say they are the best, we are the students. What students? We are the best. We have to have that kind of confidence.
Well, last one, he said your career and innovations have inspired countless neurosurgeons. What message would you like to share with young surgeons who wish to make a meaningful global contribution like you have?
See, anyone and everyone, if you think I have done, anyone can do. Anyone can do. If you think, the world is possible in neurosurgery. So when the most important issue is in young neurosurgeons or any neurosurgeon, when you are operating, if you find something that you have found something new, that's something different, you have to immediately go and write. Go to the PubMed, go to the internet, find out if somebody has written or not, and then publish. So publication is if you want to do many surgery, that is one. Surgery, operation theater is our place of worship. Operation theater, we have to enjoy the smell of the operation theater. We have to enjoy the smell of the cadaver anatomy laboratory. We have to enjoy neurosurgery. We have to love neurosurgery. We have to be in the operation. That is number one. Second thing is we have to increase our numbers. If we go and operate, even if we are not operating, we have to So if we have to, if we have to go beyond a line, we have to first is enjoy neurosurgery, we have to do neurosurgery, and we have to promote neurosurgery, and we have to write. So these are the things. There is no other way to get, to become, if you are saying, I have done, if you want to become Atul Goyal, you cannot become without writing, without having your thoughts open, without having your mind supple. Every operation you are doing, you should think differently. For neurosurgery, you don't have to have huge technology. You have to have microscope, you have to have good bipolar, you have to have good suction, you have to have good, operation table. These are the only things necessary in a neurosurgery. You want to have navigation, all right, but it is not really mandatory. If you say, I cannot do neurosurgery because I don't have a robot. But what robot you want? You don't want you should not think about robot. You should think of a good microscope. You have to good table, good bipolar, good suction. That's it. And you have to do good neurosurgery. And then you have to think and you have to write. If you can write, you can go beyond the line. If you cannot write, you remain wherever you're remaining, you cannot go beyond the line. So that is, you can talk, everybody can talk. But how many people can write? So you have to operate and you have to write.
Well, thank you. Dr. Adrian, can you say anything? Hello, Dr. Adrian, do you want to say anything?
Okay, thank you, Dr. Ahmed. I support Dr. Atul all of his speaking about the developed and non-developing countries. We should represent ourselves, and the man represented his work by the number of cases he do. The more he's learning, the more he's support his people and support himself first. Thank you.
Well, we still have some questions if John permit me. John, can you go forward?
Yeah, continue, please.
Well, someone asking if you decide to cut the C2 ganglion for exposure, what are the precautions to be taken? Dr. I think this question for you.
What is that? I didn't hear, Ahmed, what you were saying.
Someone asked if you decide to cut, if you decide to cut the C2 ganglion for exposure, what are the precautions to be taken?
No, C2 ganglions cutting is sometimes necessary to expose the joint. It is sometimes necessary. I don't do it. I described it, but I don't do it often. But if you are not able to, then you cut the ganglion. So if cutting the ganglion, you have to do little bit lateral cutting. And little bit, you have to cut the bulk of you have to make, and you have to, sometimes there's a lot of venous bleeding in that area. And sometimes the vertebral artery is quite in relation. So you have to be careful when you're cutting. You have to take care of the venous bleeding. You have to take care of the vertebral artery. Then cut under vision, under high magnification microscope. And then you cut, and then you have a big exposure.
Dr. Muhammad Al-Haj, I think. He said, many thanks for Prof. Atul for interesting speak. You are great neurosurgeon and inventor. I came across for your girl with odontoid I don't know, defect, sorry, like rotatory AED, limited rotation use body, odontoid tip attached to C1 and C6 bony defect. What to do?
Every case is different. Every case needs to be studied. You cannot make a generalized kind of a. So if you wish, you can please write to me, and then I show me the images properly if you want my opinion, and I will be certainly happy to give the opinion. On the basis.
Well, yes, sir. Go ahead. Sorry. Sorry, go ahead. Sorry for interruption. Anyway,
Hi, Atul.
Yes, Harshad, how are you?
I am fine. Great to see you again. The king is back,
Yes,
as
all
John
right.
said. And
Thank you.
I 100% agree with you. And now we are looking forward for this WFNS presidentship to be
Okay.
crowned on you. And
Thank
you,
you.
I'm 100% sure you will do wonders for the various countries and various neurosurgeons in the world. So what you said is very correct, and we have grown in India. How we have done and what we have done is very true. That we have learned on our own, and that is the best part. You said, and I agree with you. Okay, you have to learn from yourself first.
Thank you.
People
Thank
are
you,
there
Harshad.
who are mentors.
Yeah,
Thank
let me
you.
let me tell you a quick story about Atul. We had a webcast, he probably forgets, a couple of years ago, and there were 2 residents there. That's all. And he stayed like for an hour to make sure these residents understood what he was saying. He didn't need a big crowd, just 2 residents. I don't know if you remember that, Atul, but it was a while back in Nepal.
Thank you. Thank you, John. You have done also, you have taken the message of neurosurgery in all the corners. And I wish you all the best. And I wish that we are growing. You also have to take us, all of us together and grow in your campaign of World of Neurosurgery.
Okay, more questions.
Here, someone asking what is your post-op protocol? Do you give them a collar and for how long?
I give them a collar for 2 months and neck restriction movements. So this is what my protocol, and nothing strict, nothing unusual. They do start doing their work on the next day of surgery. They can use their hands, they can walk, they can run, they can do whatever. Only they have to use a hard cervical or a Philadelphia collar for 2 months.
Sorry, last one. C1, C2 exposures. Do you do it under microscope vision?
What's that?
I mean C1, C2. Sorry again. He said C1, C2 exposures. Do you do it under microscope vision?
Always under microscope vision, always.
Mm.
You cannot do this exposure without microscope, for sure.
I think that was the last question. So, any comment, anything you can say anything.
Atul,
Yeah.
the John's contribution for bringing all of us on this platform is immense, cannot be unforgettable.
No
He
question.
is really, truly master in giving us this platform to learn.
Yes,
And
yes.
I'm really thankful to you. He has done wonders for this. All of us are learning.
Yeah, I'd like to thank all of you, Ahmed, Atul, Adnan, And we'll wrap this up. We could go all days extolling the virtues of the king. But we'll wrap this up today. And thanks everybody for coming.
Thank you, and bye
Thank
bye,
you.
Emma.
Thank you.